medical misinformation is everywhere. Dr. Mitch is here for straight talk and to give you the truth.
Well, if you haven't seen part 1 on testosterone, I would do that first before listening to part 2, which we're going to do now. Now, in this particular segment, I'm going to talk about the physiology of testosterone. I think it's important so you'll understand why certain things work and certain things don't. Now, testosterone is pretty much the predominant androgen in males and is pretty much involved in multiple physiologic processes throughout the body. Testosterone production is pretty much regulated through the HPG axis with both testosterone and estrogen, providing feedback regulation to the hypothalamus and the pituitary. It's both. Now, circulating testosterone is mostly bound to two things: sex hormone binding globulin and albumin. But there is a small percentage that's also bound to circulating corticosteroid binding globulin. So circulating testosterone may stay as testosterone. It can convert to estradiol through the aromatase pathway, or it can convert through dihydrotestosterone via the 5-alpha reductase pathway. In addition to these three pathways, there's also 3-alpha androstenediol, which can also affect certain tissues, as well as those including in the nervous system, the central nervous system. So testosterone and dihydrotestosterone have different roles in the expression in different tissues, by the way. So both testosterone and DHT exert physiologic effects through something called androgen receptors. Is it getting confusing? Hope not. Or if it is, we'll watch it again and again because this is important to your clinical treatment. There's variability in androgen receptor size because it's inversely related to the function. Men who have low testosterone typically have depression or anxiety, problems with sperm production, and a host of other things, including bone mineral density issues. But if androgen receptor function improves, and then it could be an improvement with testosterone supplementation. Men with low testosterone and increased androgen receptor activity may exhibit no findings of testosterone deficiency at all, even with low testosterone, and it may not need to be repleted. Similarly, men with 5-alpha reductase abnormalities may also fail to get benefits with your testosterone supplementation when it comes to erectile function, even if they get improvements in other testosterone-related aspects. Is this confusing? Might be, and as I said, you might want to listen to this a couple times. There is a variability of when you test testosterone because of the functionality. So let me get to that for you for just 1 second. Any chronic disease, many medications can be associated with a rapid age-related testosterone decline, because with age, testosterone declines to begin with. Well, this is worsened by things like obesity, disease, other comorbid conditions, lifestyle changes, and as I said, certain medications. The way you assay for testosterone makes all the difference as well. Immunoassays are not as accurate as mass spectroscopy. The results could be 14.1% to 19.2% variable, plus or minus 40% difference if the testosterone is less than 100 nanograms per deciliter. And at low T levels, the immune assay varies by 2.7 to 14.3. So if you're not using a specific best method, which is mass spectroscopy, you could have a totally wrong information system. Now, of course, how you get it, how you grab it, how you take it when you give it, all that kind of thing, all can affect also that particular variation or something in testosterone. There's also a daily variation, by the way. So if you're going to take a particular specimen, you should be taking as close to morning as possible, because early morning is when testosterone peaks. 4 p.m. versus, let's say, 8 a.m. or 8 a.m. versus 4 p.m., Do you know the values could be 20 to 25% difference in a 30 or 40-year-old and 10% difference in a 70-year-old? Less, but still enough to make a difference. Sex hormone binding globulin, free testosterone also vary during the day. And genetics play a huge amount in variability, anywhere between 42 and 65%. So we want you to suggest that you do repeated measurements, because repeated measurements will vary anywhere in studies from 65 to 153%. It's unbelievable. And up to 50% of variation with men less than 300 nanograms per deciliter. More than 300 on repeat testing will be basically back to normal. So 2 to 3 tests will help reduce the variability. Exercise can change this. Body mass can change this. So use mass spectroscopy. Do several serial testing methods. Do it over several times, but make sure you try to do it as early in the morning as possible. Please listen to this again and again, so that when we go into part 3, so far this will all make very good sense to you and make sense why you might be getting a value that didn't make sense to you. And that's the whole reason that I'm here. I'm Dr. Mitch for Access Laboratories. For more information, go to Dr. Mitch Ghen, DrMitchGhen.com. Thanks for watching.